This video introduced the minimally invasive approach using two posteromedial portals for preserving ligament integrity in arthroscopic plural technique for posterior cruciate ligament tibial avulsion fracture. We have no disclosure. Introduction. The currently used arthroscopic technique for PCL tibial avulsion fracture that uses anterior portals and posteromedial portals is considered minimally invasive. However, it still requires cleaning the space between the ACL and PCL to insert arthroscopic instrument, which can potentially damage these ligaments. One of the key points of this procedure is creating two posteromedial portals and performing the entire plural technique through these two portals, thus eliminating the need to clear the space between the ACL and PCL. The case is 35-year-old male. He fell and injured his right knee. CT shows the PCL tibial avulsion fracture. Whilst standard knee arthroscopy is initiated with the anterolateral and anteromedial portals, it is evident that the ACL is relaxed due to the effect of sagging. Next, two posteromedial portals are created. The posteromedial area is visualized from the anteromedial portal, and two catenarized needles are inserted to establish high and low posteromedial portals. The low portal is positioned approximately 5 mm proximal to the medial meniscus, while the high portal is as proximal as possible. The skin and joints capsules are inserted with the scalpel, and the cannula is inserted into the low posteromedial portal. The arthroscope is then introduced through the high posteromedial portal using a switching rod. For the plural technique, the tibial bone tunnel area is cleared using shaver or radiofrequency system from the low posteromedial portal. If fracture displacement is significant, debris from the fracture site is also removed. The suture tape is sutured to the PCL using suture passer from the low posteromedial portal. In this case, we used a cinch stitch suturing. A PCL guide is inserted from the low portal, and the guide pin is placed from the medial side of the tibial tuberosity. If the guide cannot pass through the cannula, it is replaced with the slider for meniscus suturing. The position of the guide pin is confirmed with the C-arm imaging, followed by creating the tibial tunnel with a 4.5 mm cannulated drill. The loop of the H-bond is passed through the anterior tibial bone tunnel using the suture passer and retrieved through the low posteromedial portal. The suture tape is then relayed using this loop. During the tensioning and fixation phase, the tension lock is installed in the anterior tibial bone tunnel for temporary fixation of the suture tape. Tension is adjusted to the appropriate level, ensuring the bone fragment is stable and confirming proper tension on the PCL and the arthroscopic visualization. Once confirmed, final fixation of the suture tapes is achieved. Finally, during the anterior arthroscopic visualization, it is confirmed that sagging is resolved and the ACL is properly tensioned, while also ensuring that both the ACL and PCL are completely preserved.